Welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm Dr. Lee Frame, Director of the Integrative Medicine Programs here at GW.
And I'm Janet Rodriguez, the Office's Administrative Director. Today we're talking about empathy, chronic conditions, and more with Meghan Beier, PhD, MA, a part-time assistant professor of physical medicine and rehabilitation at the Johns Hopkins University School of Medicine.
Dr. Beier specializes in cognitive rehabilitation, neuropsychological assessment and intervention, and multiple sclerosis. She helps individuals improve memory and emotional symptoms through psychotherapy interventions.
Dr. Beier is also the founder of Find Empathy, which is an online directory and educational platform that helps connect people with challenging medical conditions to therapists who understand their diagnosis.
Welcome to GW Integrative Medicine, Meghan.
I'm so excited to be here.
Oh, and we are so excited to have you.
We're really pleased to have you.
So I guess we could just dive right in because I know I wasn't really familiar with this terminology before, but what does a rehabilitation psychologist do? And then how did you get into that field? What attracted you to it?
Yeah, that's a really interesting, tangent here is that, I started pre-grad school. I knew I wanted to do psychology, but I wasn't quite sure where I wanted to go. And so I worked for a year as a direct care worker in a place called Bancroft Neurohealth in New Jersey, where I helped people living with serious traumatic brain injuries take their medications, live independently in apartments, take them to doctor's appointments. And I just really loved that work. I fell in love with it, but I couldn't pay my bills doing that. So I decided to go back to grad school. And I thought, well, I liked this neuro part, of brain injury. So maybe I'll be a neuropsychologist. So I found a health psychology grad program that had a neuropsychology minor, and I got into that. And what I realized is that a lot of neuropsychologists, I won't say that this is true across the board, but they really just do assessments and then they kind of recommend the person moving on to other people to do the intervention. And so I missed wanting to actually work one-on-one with people. And what I found was that rehabilitation psychology is this nice merging of working with people that have medical conditions, but actually helping them reintegrate into life. And so a rehabilitation psychologist is a psychologist that specializes in working with people that live with a chronic illness or disability.
Yeah, that's fascinating. And I totally understand that path. That makes a lot of sense. You're like, I wanted to help people. I want to be working with people and getting to help them in this way. What does a regular day look like for you?
Well, it's a little all over the place right now because I'm wearing many hats. But I would say in my clinical work, I do a little bit of everything. So I might start the day off with somebody who is coming in with cognitive concerns. I mostly work with multiple sclerosis at this point. So, an individual who maybe talked to the neurologist and the neurologist said they told them they were having concerns about their memory or their cognitive functioning. So I would dive into that. I do, a more in-depth clinical interview to find out all of the potential things that are impacting their cognition above and beyond multiple sclerosis. So that might look like, what does their sleep look like? Do they have any ongoing chronic pain? What kinds of medications are they taking that might be impacting their cognition? We might do a 2-hour, I typically do short batteries because it's more clinical focused, not necessarily something that a traditional neuropsychologist would do, but about a 90-minute to 2-hour cognitive assessment to find out what exactly is happening. But I also do psychotherapy. So many times I use what I found in that initial interview and kind of getting to know the person to really inform what kind of care is going to happen moving forward. So that might look like, changing some of their day-to-day behavior habits. So we might focus on sleep or managing pain, but it might look more like managing emotional concerns, because we know that anxiety and depression impacts cognition as well. So it might be more traditional psychotherapy. And a lot of it is partnering with the medical team, other rehab professionals. So it's a lot of interacting with the team surrounding the patient as well. So that's kind of a typical clinical day for me.
That's very helpful. Thank you. And that definitely feels very integrative to me. We've got the team-based medicine. There's clearly a very strong patient-provider relationship, and you're really doing kind of a whole person care approach because you're dealing with their emotional well-being, their mental well-being, and I'm going to guess even a little bit of their physical well-being. Is that correct?
Yeah. Yeah. I've had to learn a lot of what the physical therapists do, what the physicians do, occupational therapy, because I think that plays a big role in people's emotions too. If they're afraid of falling, then we have to address that. We have to know kind of what what are the skills out there? What ways can we help somebody either regain more strength or more balance, or how do we address that fear through other means? So yeah, there is a lot to do with understanding the physical side of things as well.
Well, I am, and I wouldn't wish any condition on anybody, but I am envious that that this specialty exists now.
Mm.
When I was diagnosed with breast cancer in 2002, and this would have been incredibly helpful
Yeah.
to have somebody like you around. Okay, so what's the story behind Find Empathy?
Well, very similar to what you just shared. I was hearing from a lot of people, if they finally made their way to my clinic or to my room, they would say, "I didn't even know that somebody like you existed."
Mm.
And I actually had a conversation with somebody recently, who runs an online business for individuals with chronic illness. And she said, I've been doing this work for more than 10 years, and I didn't even know that there were psychologists like you out there. And there's not just psychologists, there's social workers and master's level therapists and counselors who do this work as well. And I think one of my goals was to help patients, families, and even medical providers, because I think sometimes physicians don't even know that we exist, realize that there are people like us out there, and then have a place for them to find us. So I started off Find Empathy just as an online website, a directory to try and start listing people who do this kind of work so that people can find us. But then it kind of morphed because I do a lot of work also with community organizations, and I really like being a consultant and speaker for patient organizations and advocacy boards. So one of them actually said to me, Meghan, we have trouble finding people like you. What if you were to do something like education to help more therapists who are seeing people in the community learn about how to work with people that have chronic medical conditions, or a disability, and or even an acute medical condition, right? There are people who are coming out of the ICU with medical trauma, and so how teaching those people in the community who are doing the work or seeing people coming out of hospitals how to more effectively work with their medical condition as well. So that kind of got me started on doing community or continuing education. So I went down that pathway as well. So I'm just trying to really connect the dots between what people need and the medical system, and then helping mental health providers be a bridge between those two things.
Well, I love the website, and I suggest that our listeners go and check it out. And just thank you for coming up with this brilliant idea.
Thank you very much. I mean, I really hope that it helps. I have heard a lot of excitement from patients who are saying, this is a great resource for us. So I'm really humbled by that. And I hope it continues to grow so that it is a resource for more people.
So what about other healthcare providers? Is this a resource that they could be utilizing to better assist their patients?
Absolutely. There's a couple of organizations that we're starting to work with now that have, and MS is my world, so that's where I started, so Consortium of MS Centers and the National MS Society, who are using Find Empathy as a resource, putting it up as a way for physicians, neurologists, nursing staff to be able to find mental health providers. So I hope to keep growing that list. It's free to be on the website. So any mental health provider who wants to be on there can be on there completely for free, no catch. Really, it's a resource for patients, family members, and medical providers.
Wonderful. So hopefully all of you listening out there, if this is your space at all, we'll be reaching out to get listed.
Absolutely. I would love that.
So you chose the name Find Empathy. Obviously, empathy is part of the work that you do. Can you tell us more about that and maybe the science behind using empathy in this field?
Yeah, absolutely. I think, I really love Brene Brown's work. And one
Me
of the
too.
things that she's great. So one of the things that I've heard her say, and that's kind of stuck in the back of my mind, is that empathy fuels connection. And we know that empathy, it comes from a German word that means emotional knowing. And, in one research article that I read about empathy, it kind of described it as an emotional bridge. And kind of with all of those things in mind, one of the things that I kept hearing from many of the patients that I was working with was that they felt really disconnected because of their medical disease or condition. They felt misunderstood. They didn't feel like family, friends, society at large really understood what they were going through. And often if they saw a community mental health provider, now I won't say this is true across the board, but some of the people that I was working with said, if they saw a community mental health provider, they also didn't always feel understood. They felt like they were having to explain their medical condition. They were having to educate the therapist, and that was taking up valuable time, resource, and energy. And so, I think one person I talked to recently described it as, they had to, be the source of information and then the filter thereafter, so that everything, they had to keep correcting the therapist. And one thing I hear about a lot is fatigue. And, sometimes if you're a traditional mental health provider, you think of fatigue as maybe a symptom of depression and we want to get behaviorally activated, but we're not taking into account how fatigue might be being driven by a medical condition like treatment for breast cancer, chemo, or by something like a neurologic condition like Parkinson's or chronic fatigue syndrome. And so, really kind of understanding the medical side of it is important in order to give good therapeutic advice as a mental health provider. So I kind of picked empathy because I wanted patients to feel understood. And I also wanted the therapists who are working with them to kind of have that emotional knowing. So they're the emotional bridge, but they also know about the medical condition. So that was sort of all of the thinking behind that name.
That's wonderful. And I think it further helps us understand the importance of someone like you, because spending very valuable therapy time explaining the fundamentals of your diagnosis is not really what you want to be doing as a patient who's there for psychological help.
Right, exactly. Yeah, you want to get to the meat of the issue, not have to try and explain why, my fatigue is not depression related.
You're also an active multiple sclerosis researcher. What is your focus?
Yeah, so most of my research is on cognitive and emotional symptoms, but I will say that the majority of the research that I've done has really been fueled by this passion that I have to make our assessments and our treatment more accessible. I think even from my postdoc and grad school, I felt like a lot of what we were doing in the academic world wasn't making it past the walls of academia, or very rarely or only to a select group of individuals. And so I really tried to focus a lot of my research on ways to make things that we were doing more accessible, more efficient, easier. And since I was doing work with people with multiple sclerosis, one of those things was screening for cognition. So I think it was in 2018, I was part of a group with the National MS Society where we put into guidelines that every individual with MS should be screened for cognitive dysfunction at least once per year. Prior to that, there were no guidelines about that. And so very few individuals were really getting screened, and it's a huge part of living with multiple sclerosis. But the fact of
That
the
is
matter—
so shocking that it didn't exist.
Yeah,
It's
yeah.
just one of those blind spots.
Mm-hmm.
Exactly. And I think a lot of people were saying, this is a huge problem for me. I'm losing my job because of it, or my relationships are being impacted, and it just wasn't being addressed. And some of it, I think, was because, there's not a lot of, outside of major medical systems, it's hard to find people that do interventions for cognition. I think that's changing, especially with the advent of more telemedicine work. But people just weren't getting screened, and screening took time. It wasn't efficient. So in my postdoctoral fellowship, we created an app to take one of the recommended standard screenings called the BICAMs and turn it into an app so that anybody could pick it up and administer the screening. The challenge there was that all of these different tests that were in this recommended screening are all copyright protected by different companies. So trying
that doesn't
to get
sound
all
fun.
So trying to make that happen in the real world and get all of these different companies to agree for it to be a part of one app was fine for the study, but not so fine afterwards. So we've been working with a group out of Harvard called the Many Brains Project, and they have something called the Test My Brain website. And all of that's open access and free. And so we've sort of compared that recommended screening, the BICAMs, to a comparable online assessment that they have freely available. And we found, at least in our pilot study, that there was really no significant difference. So a lot of the work I'm doing is really trying to figure out how can we make all of this more accessible so that people all over the country, all over the world can get these screenings and interventions more effectively.
Wow. So access is obviously really important. But one of the things that I always think about when I think about cognitive assessments is the time that it takes to go through those assessments. Is that something you're also working on?
Yeah, so in the MS world, we've boiled it down to that there is what's called the symbol digit modalities test, the SDMT, which is 90 seconds to administer. But, it's interesting because even some of the neurology teams that I've talked to said even 90 seconds is too long, because when you do 90 seconds plus having to score it, plus having to put it into the chart, it's really like 5 minutes. So 5 minutes out of a, 15 to 20 minute visit is still a long time. So I actually worked with another colleague who shortened that test to 30 seconds and found that the 30 seconds of the SDMT is still a good screener. But, one of the things with the Test My Brain platform is that it's all administered online and doesn't necessarily need to have somebody there. So it's something that could be sent, a link that could be sent home that somebody could do at home. Now, there's always barriers, right? Because there are many people who don't necessarily have access to computers or a smartphone. And so we have to think about that as well. But at least for those that do have access to that technology, it might be one way for them to get that assessment outside of the office and then have, talk to the physicians about that when they get to the office.
Yeah, absolutely. And perhaps maybe for those people that don't have access at home, having a station in the clinic where they could complete it prior to meeting with their visit, so it's not taking up visit time.
Yeah, exactly. There's a neurologist in New York, on Long Island, who that's exactly what he does. He has a few computers set up in his clinic, and he just brings people in early for their appointments, and then sits them down and has them do it in the office. And he's very passionate about the importance of all of this, and I also think that he's doing a lot of good work tracking people's their progress in the MS progression because of that, and not just with walking measures, but also cognitive measures. And he's catching things earlier than I think a lot of people in the general community.
Wonderful. It's such a message of hope and promise. And this is what we want to hear when we're doing research, right? We're actually going to affect change. It's not just, like you're saying, to stay within the walls of academia.
Exactly. Yeah.
So what else is in the pipeline in terms of research or even, clinical care? What are you looking forward to seeing in the future?
Yeah, I've really loved seeing a lot more push for accessibility in treatment. At least where I am at Hopkins, I have some colleagues who are doing virtual group-based therapy using DBT strategies with people with chronic illness and their caregivers. Our department is doing some precision medicine work where they're trying to track people at home. So sending, intermittent surveys, as well as, providing smartwatches so that they can see people's movement before and after surgery, those kinds of things, so that we're kind of breaking down the walls and really able to catch people earlier before there's more progression or more decline, or seeing when people maybe need to be brought back in for more rehab, if after surgery people are not as mobile as they were before, something like that. So all of these kinds of initiatives that I'm seeing both within Hopkins and around the country are really exciting for me. Really my main passion is that I think, we need to be, those of us who do this work need to be more accessible to everyone in the country, not just those who can access an academic medical center.
Well, amen to that. And I'm sure Find Empathy will help as well, just getting people aware. And hopefully this podcast will help as well with awareness. And people will get the care that they need. What about tips for healthcare providers? One last little soundbite. If you are a healthcare provider out there who maybe has never heard of this but works with patients who have chronic diseases, what's the one thing they can do to really assist their patients?
I think it's being there with them and not rushing to fix the problem. So I think it's sometimes just sitting in the emotion with somebody. So I'm thinking of a visit that I just had recently with a patient that got some bad news. And when she shared her immediate reaction, which was really frustration, sadness, grief, the medical provider that she was working with immediately jumped to another solution. And she reacted to that because she was like, that's not really the solution that I wanted. I just needed somebody to hear me out. And so I think for me, one of the things that I really keep in mind when I'm working with people is this sort of dialectic that sometimes we just need to sit and really empathize, really hear where somebody's at. And once they feel heard and understood, then we can shift our thinking to what's the next step? How do we problem solve this? How can we help you to be more integrated in the life that you want? But we really need to also, the person needs to feel understood before we can do that.
Well, that seems like the perfect end note for our talk. It is all the time we have for today. Meghan, thank you so much for joining us.
I'm so happy to be here. Thank you so much for the invitation.
You can come back anytime.
Absolutely.
Thank you.
This is the GW Integrative Medicine podcast from the GW Office of Integrative Medicine and Health.
I'm Dr. Lee Frame.
And I'm Janet Rodriguez. Thanks for listening.
The Office of Integrative Medicine and Health produces the GW Integrative Medicine podcast with funds from your donations. Your generosity allows us to raise awareness of the benefits of integrating whole person care, including evidence-based complementary therapies, into healthcare broadly. Help us continue to grow the podcast by making a tax-deductible donation on our website, smhs.gwu.edu/OIMH. Click the Give Now button while you're there. Sign up for our free monthly newsletter for even more evidence-based content, including free webinars.